Okay, our first presentation is entitled Voices from Oklahoma's Primary Care Clinicians During the Pandemic. And Dr. Stephen A. Crawford is a Senior Associate Dean and Director for Healthcare Innovation and Policy at the University of Oklahoma's College of Medicine. Dr. Crawford is also a Professor of Family and Preventative Medicine and is the former chair of the OU College of Medicine's Department of Family and Preventative Medicine. His role as the Senior Associate Dean will continue support for existing research efforts in dissemination and implementation, that's DI science, with a focus on translating research findings into community settings. D&I research is the foundation of the projects performed by the Oklahoma Primary Healthcare Improvement Cooperative, or OPHIC, the community engagement resource for OU Health Sciences Clinical and Translational Science Institute, where Dr. Crawford is co-director. Under Dr. Crawford's direction, OPHIC launched the Healthy Hearts of Oklahoma, or H2O project, in 2014. It's a $14 million grant from the Agency of Healthcare Research and Quality with the goal of improving heart health across Oklahoma. Using in-practice facilitation and peer-to-peer discussions with primary care providers, the H2O project showed significant improvements in the use of aspirin, blood pressure control, cholesterol management using statins, and the reduction of smoking in patients across the state. Subsequently, the D&I model is being used to address the state's opioid crisis, diabetes management, and improve screenings in practice for unhealthy behaviors. Dr. Crawford understands the needs of Oklahoma's primary care practices as he oversaw a vibrant academic clinical operation whose faculty is involved in all levels of medical education, pre-medical through postgraduate. He continues to see patients on a limited basis, and he and his wife live in Oklahoma City area. Dr. Dan Duffy is an internal medicine and medical informatics physician from the OUTU School of Community Medicine, where he served as dean and holds the Steve Landgarten Chair of Medical Leadership. Since 2015, he has been the co-director for the Oklahoma Primary Healthcare Improvement Cooperative, OPHIC, and the principal investigator of the Agency for Healthcare Research and Quality's Evidence Now Healthy Hearts for Oklahoma, or the HTO Research Project. He has also led OPHIC's efforts on the current pain and opioid management Do No Harm program with the Oklahoma Department of Mental Health and Substance Abuse Services, as well as the new SBIRT program. Dan was the primary author for the online CME training program on pain and opioid management that is available for all clinicians on the ODMH website. Dr. Duffy guided development of the School of Community Medicine that includes a summer institute for multidisciplinary immersion for incoming students to understand community medicine, a faculty academy in community medicine, and a student academy to help third-year students learn skills to provide care to underserved patients suffering from chronic illness. He provided leadership for OU Physicians Tulsa's efforts to adopt the patient-centered medical home, the Tulsa community to pursue the both comprehensive primary care, or CPC Classic and CPC Plus, Medicaid care coordination, and to obtain a Beacon Community grant that evolved into My Health Information Exchange. Dan was Senior Vice President for the American Board of Internal Medicine, a member of the quality committees of the National Committee on Quality Improvement and the National Quality Forum. He was a founding member of the Academy on Communications in Healthcare, a regent for the American College of Physicians, and a member of the American Board of Medical Specialties Board. He has been honored with the Stanton L. Young Master Teacher Award and the OU's Edgar Young Lifetime Achievement Award. He served Tulsa as a board member of the Community Service Council, My Health Access Network, the Oklahoma Center for Healthcare Improvement, and the First Step Male Corrections Diversion Program. Dan lives with his wife, Kay, in Tulsa, has one son and two grandchildren who live in Chicago. Please join me in welcoming Dr. Dan Duffy and Dr. Crawford.
Let me just say how glad we are to be here for this presentation. And we're going to make this pretty casual. Steve and I have learned how to kibitz back and forth and step on each other's words, add to, and we've done this for so long. And although Zoom is something new for many people, we have been Zooming or WebExing or whatever program we were allowed to use for the past 6 years. In fact, I think Steve and I have only spent about 8 hours face-to-face over the past 5 years. And yet we really have worked hand in glove for a long time. So let's go to the next slide, Steve. You take it away.
Well, we first want to talk about our own OPHIC, and we'll go over the acronyms that you all may not know. OPHIC is the Oklahoma Primary Healthcare Improvement Cooperative that's based at the University of Oklahoma. And we obviously have been involved in an SBIRT project that we're reaching out to practices around our state to help them implement SBIRT, as Takia mentioned. We also are involved in another project now called H2O Plus, or Healthy Hearts for Oklahoma Plus. Our previous and one of our original projects was the Healthy Hearts program that reached out to over 250 practices in our state to help them implement heart health prevention. And because of that success and how well we were able to do, the State Health Department reached out to us to assist with a project they were working on similar to this, but also to involve diabetes prevention and diabetes management. And that's what we've now called the H2O Plus project. And with the impact of COVID-19, we've had to implement ways of doing remote screening, how to do telemedicine brief intervention with our patients, and also how to do telemedicine referrals, which we think is very important during this time of COVID-19 and patients' hesitancy to come in. And still, we think it's important to encounter them in their environment to help them during this very trying time.
So Steve, what do we mean by remote screening in this context? I know we'll get down here to the problems later, but what do we mean by remote screening?
Well, the remote screening that we've been advocating is to do it you could do it as a telemedicine type of screening method that allows you to get on a call with the patient and provide that type of screening. The other thing is many practices now have electronic health record that has a thing called a portal. It's like having an email that allows you to send a secure message, a HIPAA secure message to patients, and provide the SBIRT screening tools to them prior to the visit. Whether they do a telemedicine visit or whether they do an on-site visit, we can provide those particular forms that can be used as a screening and then send that information back before the patient visits so the clinician and the clinician's team has it ready when the patient is seen, whether it be by a telehealth visit or by a on-site visit.
Yeah, it was interesting as we were beginning to roll this project out and began working with practices to institute the tablet in their practice to do the SBIRT screening in the really terrific automated system that the mental health department has put together. Practices were worried very early on in the COVID epidemic that they'd have to do a lot of cleaning of that tablet to have patients use it. It wasn't but a week later that we realized patients weren't going to be coming in very often. We needed to have the screening available. And so we began looking at ways of sending that screening invitation to the patient either the day of the visit or the day before the visit. So with the terrific staff from the mental health department, we worked out a way that we can actually send the screening tool to the patient's smartphone or to a patient's computer or to a patient's tablet. And that was moving along just great. Everything was ready to go and we were getting ready for that to be set up and realized that innovation for COVID may be something that's really practical for the long haul. Well, we were thrown a curve over the past couple of days in which the invitation to do that screening may have some HIPAA compliance issues that we're working out right now. So remote screening is still a distinct possibility. The COVID epidemic has caused us to solve problems that I think will be lasting solutions, but every problem has a second or third problem that comes with it. The telemedicine brief intervention, Steve, is pretty much doing a telemedicine visit, responding to the SBIRT results. And likewise, telemedicine referrals have been going on in Oklahoma with a number of behavioral health specialties, and this COVID epidemic has only enhanced those.
And again, our response to the challenges associated with the potential challenges of getting that screening out to individuals, which we thought we had fixed. We're working with many of the practices who have portals to use that method rather than others. And many may have experienced that opportunity to send messages back and forth with your clinicians that you see personally, to send a message. And that's becoming more common now, not just because of COVID-19, but the implementation of electronic health record and what's called meaningful use.
So Steve, the changes this has caused to us at OPHIC are pretty substantial, since our model involves, we didn't use Zoom much with our practices before COVID occurred, because our approach was to actually send clinicians into the practice for what we call academic detailing visits. Our practice facilitators did in-person recruitment and enrollment with the practices, so they got to know the practices. And then all of their facilitation visits, which ranged from 6 to 20 visits, depending on the project, were all done in person. So what have we been working on with OPHIC now to try and transition from in-person to telecommunication?
So some of the things that we've had to do is to figure out how to do remote recruitment and enrollment and e-consenting to participate, as what we do are part of studies, and including doing surveys of the clinicians and their staff, because we do that to get a sense of the practice and how they're doing, in addition to, as Dan mentioned, about providing the e-facilitation and trying our best to figure out. It's not been without some challenges, and many of our practice facilitators are online, they're listening to this, and they can certainly concur with that particular challenge to try to reach out to practices, not only with the recruitment and enrolling those that are interested, but also then trying to implement the guidelines that we're trying to support.
Yeah, terrific. And this last bullet on remote and video peer consultation visits with the academic detailer guide, one of the most rewarding parts of the OPHIC projects has been clinicians having an opportunity to go into rural practices or practices all over the state and have a conversation with the clinicians in those practices about the implementation of whatever the project included, in this case, SBIRT. So Steve, do you want to comment a bit about how we're making modifications to the academic detailer visit?
Yes, thanks, Dan. We've actually done some videoing of Dan and I doing a academic detailing visit or peer-to-peer consultation over the guidelines, where we go over the particular document that we normally would give them a hard copy, and at this point we would probably be sending that out to our clinicians and then sharing that during a teleconference like a Zoom, but then we've recorded it to be able to provide that for future use, whether the clinician wants to watch it or whether they want their staff to watch the clinician peer-to-peer consultation or academic detailing. And then for some reason, if those clinicians could not make it, it's certainly going to be available to them, with Dan and I providing kind of the similar repartee that we're doing during this conference.
Great. Well, Steve, you've done something else, and that's going to be the guts of the remainder of what we have to say, in that you've been collecting the voices of primary care clinicians during the COVID epidemic. We realized we had the opportunity through a group called the Partners Advisory Council. We had a number of clinicians, 10 or 12, who have been working with us over years, looking at the projects that we've been doing and giving us advice. And we realized you and I just don't know, except from our narrow windows, yours at the University Health Sciences Center in Oklahoma City, and mine from my office here at home, quite frankly. Haven't been out at much at all. But we did have clinicians on our advisory team that could meet in a roundtable once a week, which we've done now for 3 weeks, and talk about what is it like for the primary care clinicians. Now, for everybody on the call, it's important to realize we're talking about people in those small practices. We're not talking about the folks who have worked in emergency departments or in the ICUs dealing with the sickest of the sick. So Steve, do you want to take it away and talk about what we've learned on the roundtables?
Yes, and this listing that's on this particular page is just a fraction of what the questions and issues that have come up and that we've investigated to try to find information for our primary care clinicians. The first that was brought up was testing, and I'm certain that many of you have questions about testing, and we've done some investigation on that particular topic, both on the side of the what's called the PCR testing that most everyone knows about, and the other is on during the very first 3 weeks ago was the question of antibody testing or the blood test to see if you're immune or not, and what information do we trust and what types of tests should you trust and how do you deal with positive and negative tests and that type of thing. And I was able to find some information and send that out. We can go over that if anyone has questions.
Do we have a bottom line, Steve?
Well, the PCR, there are a limited number of FDA approved PCR tests, and those are the tests to note whether you currently have the virus on your body, and particularly in your nose or in your spit. Those are some new tests that have come out that make it easier so you don't have to have a swab put into your nasopharynx. And it's not just in your nose, it has to go back pretty far to get the proper testing for the original PCR test. And PCR is a long word that probably you don't have to know that. That's just the acronym that clinicians use. The other testing that you all have heard about is the serologic or antibody testing. And many had hoped that that would be a way we could test for immunity to the COVID-19 virus. The problem with that is that it's not to be used for diagnostic testing. That's the first important thing. The second is there's just a very limited number that have been FDA approved out there, and many that are being marketed around the country are not FDA approved. The third issue is that we don't know what having antibodies mean, whether it truly provides adequate immunity to secondary or subsequent infection. And the last is that the testing is not necessarily specific to this particular virus. There's a wide variety of coronaviruses, the original name of that class of viruses. And there may be cross reaction between one coronavirus and another. So again, we don't know whether that immunity is helpful. The one place where this can be helpful is in epidemiology, to know the percent of positives, say in a state or in a region or in a community, to know whether we have adequate, and then watch to see if infections do occur over time. But we have to remember that we didn't know anything about this until about December 31st, this virus. And it's been within the last 5 months, we've discovered this much, and we're getting more and more information, and the information is changing rapidly.
Thanks, that's very helpful. So the second topic was one of concern, the mental health resources that these primary care clinicians are needing for their patients and for their providers, and even more importantly, for their staff. What have we learned there, Steve?
Well, that is true, Dan, that those resources are critically important for all of those groups you mentioned. And people have probably seen and heard about the staff of health facilities being stressed. They're not certain about their own safety and the safety of their families, but also our patients who are fearful because there's a lot of inconsistent messaging going out regarding this particular. And part of the inconsistencies has to do with the evolving nature of this disease. And as we know more and more information, but we think it's important that that our primary care clinicians provide appropriate resources to their staff, to themselves, and to their patients.
Yeah, the availability of the telemedicine for mental health resources is one thing that several of the providers pointed out was truly valuable to them. The thing that is the problem has not been so much now as there's the fear that the mental health issues are going to become more severe as this drags on and on and on. How about this idea of protecting patients and staff, that PPE or personal protective equipment, environmental disinfecting, and how you even see patients in the office with the threat of COVID?
Right. Part of this is not only to protect the patients, but to protect the staff and the clinicians that are seeing these patients, because people may know that patients can, and all people can be asymptomatic carriers. So we have to assume when you're going to a clinical setting and when you're going to be in close quarters with any person and dealing in a clinical setting, we need to have adequate protection. And for the general public, there's one kind of standard, but in a clinical setting, you need another standard, a much more rigid. And the problem has been is that initially during the initial upswing of the number of infections, we were worried about the amount of PPE being available for clinical practices. The state was providing some to particularly high-risk hospital settings, and others that then moved to the nursing homes. Primary care was kind of left in a lurch for a while, but with some intervention and some information, we were able to get out to our primary care clinicians. They were able to find access to that through our state health department. So that has become available. The other issue is what to do with the environment, because the virus can land on surfaces and in the air, though that doesn't last a terribly long time compared to surface contamination, and how best to clean surfaces and that. And we've given information from the CDC to our practices around the state. But I would tell most people, as I have in many settings, is masks protect others. When you wear it, you're protecting people you're around from you carrying the infection to them. Wearing gloves when you're out in the public and in other areas protect you from picking up the virus and accidentally touching your face. Obviously, the mask helps you from touching your face or your eyes or your nose, but the gloves help protect you from picking that up. When you're in a clinician's office, the clinician may wear much more protection, such as a face shield, particularly if they're dealing with people who are actively coughing and sneezing, because that can be, the virus can transmit through droplets in the air and then through eye mucosa, nose mucosa, and such.
Terrific. And one of the things that a number of the rural practices realized is that when they didn't have the capacity for telemedicine visits, it became really important that they screen the patients in advance with questions. Do you have a fever? Have you been in contact with anybody who has symptoms or is diagnosed, or have you traveled to endemic areas? Then they ask the patient to wait into the car until their visit time. And then in some cases, the clinician goes out with PPE on and sees the patient in the car, not in care,
Right.
delivers the care in the car. Or they have a room isolated in the clinician's office where they will see COVID patients and do the disinfecting of that room. So I think people have been very creative in doing this. The telemedicine visit was a topic of hot conversation.
Yes,
I
it
think
was.
some of the practices realized that they had to drop to about a third of the number of visits about 2 or 3 weeks ago, and were really worried about the viability of their practices. And then they quickly began adding telemedicine visits. Can you say more, Steve, about what we learned about telemedicine?
Yeah, telemedicine has been around for quite some time, but it hasn't taken up until this occurred. But it's been a rapid type of learning for many practices. One, you have to figure out the right platform to use, and there's a variety of products out there that you can do telemedicine on. With the onset of the pandemic, our federal government and through their insurance products such as Medicare and Medicaid have loosened up the guidelines. They used to require that the patient be in a clinical setting to do the telemedicine visit for Medicaid particularly, but they've loosened that, and it seems to have been a very burgeoning area, including using almost any platform, whether it be just plain telephone to FaceTime on an iPhone format to other more medical ones that are free and available to clinicians to use, such as one called Doximity, the other one called DoxyMe. But there are many other platforms that people have used out there. The other challenge has been is how do you bill for those products or for your visits on telemedicine? Again, clinicians who haven't been familiar with doing telemedicine needed to learn those codes or have their staff learn the codes, and also how to document the visit, because most telemedicine visits require that the patient consent for the visit by whatever means they're using, and it has to be documented. And secondly, you have to use particular billing codes to properly bill. From what I've heard, and from our conferences on the phone, or televisits, as it were, that we've had, they seem to be doing well regarding getting reimbursement or paid for those types of visits.
Yeah, that's really terrific. I think it was curious that one of the clinicians on the call said he was shocked at how effective the telemedicine visit was. That when people had a thermometer at home, a scale at home, a blood pressure cuff at home, and you could actually interview and see the patient, you could do a very credible, valuable examination. And he even questioned whether or not the hands-on examination added a whole lot more. That was a way of going about saying, you know, the telemedicine visit is probably here to stay in primary care, even beyond its use in mental health and counseling.
Certainly, Dan, that's very critical in regards to why telemedicine may become much more prominent in primary care and in other parts of medicine too. There's even some of the other telehealth techniques or tools that may be coming out to assist clinicians in caring for patients, not only having blood pressure cuffs, but in thermometers. There are thermometers now that read through Bluetooth that can transmit that information. As most people know, there are, you can do at-home diabetic tests, but now there's ways you can measure oxygen at home. The thing called the pulse oximeter has become very inexpensive and is available for use in the home, and you could monitor somebody with respiratory symptoms to see if they really need to come in to a clinical setting or into an emergency setting.
Yeah, right on. Following up with our Do No Harm or Pain and Opioid project, we realized that by relaxing the requirement for a face-to-face visit and allowing telemedicine visits for the chronic pain and opioid prescribing visits, that has been also very helpful to the primary care clinicians, and they think working quite well.
Yes, and if most know, starting January of this year, there was a requirement that physicians, except in certain very limited situations, had to e-prescribe all controlled dangerous substances. And so that's kind of helped with this process, because in the past, particularly with Schedule II medications, they had to be handwritten and a script given. But now the state law, not related at all to the COVID-19 issue, but because of the prior opioid issues in our state, required as of January 1st that e-prescribing be done for all controlled and dangerous substances. There's actually still a very limited number based upon certain EHRs that have to be handwritten, but those are very few and far between.
So this idea of funding, I don't think we need to get into it very much with this audience, but the primary care clinicians initially were really very concerned, particularly the small ones, about the drop in revenue. They're really cash, hand-to-mouth practices, and if the patient volume diminishes, their revenue that sustains their staff and pays salaries falls quickly. I was very pleased to learn that all of the practices we talked with were able to get the PPP support from the federal government. They were able to get bank loans to keep the practices open. And although it was an initial fear, it over 2 weeks seemed to dissipate some, and that the practices found themselves being able to keep their staffs open, keep their practices open with a combination of telemedicine and live visits. It's also interesting that patients prefer either or. Not every patient likes a telemedicine visit. Some still want to come into the practice and trust that the practice is going to keep them healthy. You've already mentioned the changes in insurance coverage for telemedicine that made it easier for telephone calls. What's this issue of advising families and spending time dealing with families of patients rather than the patients, and this bit about the safe to return to work?
Yeah, this is a big challenge across our state and the nation, is when is it safe to return to work? When can people who work in certain situations be back at work? Whether they've been infected or not, whether they have health issues or not, whether they're over 60, as many have said, and that's an important aspect that primary care clinicians are being asked. And we've brought them some information on those particular issues, but also how do families deal with this issue when you have children that are at home all the time, and how do you help those children deal with the stressors that their parents are dealing with? And they may talk with their fellow students and through their tele-education visits and getting that sense of stress, and they may be acting out too, and how to deal with those particular issues have been kind of themes that have come up during our calls.
Yeah, and the primary care clinicians are a little troubled by the confusing messages that patients are getting from their employers. Some employers insisting that testing be done before they return to work, but not being very specific about the kinds of testing, meaning we already talked about the problems we clinicians have with trusting the tests, that the messages people are getting are vary across employers, and that the clinicians realize that patients come to them trusting them to have the answers, and they feel pretty insecure about how to answer it. So what about this giving of recovery plasma, Steve? I found that really interesting.
Well, it is. The issue, one clinician particularly asked, because he had patients that said, okay, I had COVID-19 and I'd like to donate my plasma or my blood to help others, because there has been, and I would say it's still in an experimental stage. It isn't necessarily approved outside of a research protocol treatment for COVID-19 patients who are very sick is to use what's called convalescent serum, meaning the blood or serum out of a patient that had COVID-19 that has developed antibodies, and then how does somebody donate their plasma if they're willing and wanting to do that to so others can benefit from their ill fortune of having COVID-19. And so we found out, at least in our central Oklahoma area, the Oklahoma Blood Institute does have a program that you can go to. You can just go onto that Oklahoma Blood Institute website and find the link. It's called BioLink, I think, is the actual area on their website that allows somebody who has had it or believes they've had it to volunteer, and then they'll get in touch with that person to see if they're an appropriate donor for recovery plasma. Now, does it work is another question. Some have believed it has in prior infections like this. They've used this even back, I believe, in the 1919 influenza pandemic, that some have equated were somewhat similar in what's happened then and what's happening now, that they used a similar method. So it's not a new fancy type of thing. It's an old method of using people's recovery and helping others.
So yeah, that was very helpful, although we haven't seen much of the results of that in any systematic study yet. So the other issue was how is primary care handling these post-hospitalization follow-up patients? And what we're finding out is the sickest of patients are either going to a convalescent center, a nursing home, or a site like that, rather than coming home and following up with the clinicians. Those that aren't as sick are just like follow-up for the flu or even a cold, that it's routine business as usual. We also inquired about whether the patients with chronic diseases such as heart disease, diabetes, strokes, or chronic kidney disease who have also become infected with COVID-19, what are the problems that they are having? And again, our primary care clinicians basically said those are hospitalist issues and nursing home hospital issues rather than primary care office issues. What do you think about that, Steve? Were you surprised at that, or?
Yeah, well, somewhat, but we knew that, again, the population that's getting hospitalized are the older usually. The numbers that are the younger that get discharged directly to home are usually the less chronically ill, because those that are chronically ill may need to go into the convalescent for recovery, because even though they're over their acute medical need to be in an acute hospital setting, they still need recovery because it is something that persists, the symptoms. Even those that are ambulatory. I've been discussing this with a individual that's that I know up in our work area that had a positive COVID-19 test and had symptoms compatible with that, and 3 or 4 weeks out is still having not fever and that type of thing, but is having heart symptoms that she hadn't had before that worries her and that she's being evaluated for. But those types of things that have happened are things that are that we're going to have to follow up, that primary care is going to have to deal with. The most recent is for children, this new multi-system inflammatory disease that some have equated to what's called Kawasaki, that causes an inflammatory response throughout a child's body that doesn't seem to at least declare itself as readily in adults, though some of the things that have happened to adults is very similar. But we thought children would be relatively immune, and these are rare, but still happening to some children.
So the last question that came up was, did we really have a lower surge in Oklahoma than we expected? Why was that? And do we actually have a healthcare system that has much more capacity than we expected? Because it looks like our hospital and ICU and ventilators were never stressed up to this point.
Well, what we've heard from those in the know on this is that yes, we flattened the curve that we believe was going to happen, though we're in a much less densely populated area, being in central Oklahoma or even all over Oklahoma, than a place like New York City or Detroit or New Orleans. And though we do have, unfortunately, a fairly unhealthy population physically, and unfortunately also mentally, but physically, that seems to have helped protect us some. We're also at the distance from the coast where it seemed to concentrate and where more international visitation or occurs in those coastal areas. And we took appropriate action to kind of go into containment mode, which I think truly helped us limit the spread. Now, obviously, everyone knows we're coming back into a ramp up. And I do know that for sure our experts in public health are watching this very closely. I was on a call last night with our interim state epidemiologist, and he definitely said that they're watching this very closely and monitoring it. And it's not a time to let our guard down. And wearing masks when we're out in public to protect others, and wearing gloves. If you're going to be encountering places where you can't predict what you're going to be touching, is probably still the best advice.
Well, thank you very much, Steve. And this was a lot of fun to share our experience. Not a lot of fun to go through this.
Oh.
We are getting, I think the benefits that are going to come out of this experience are extraordinary. Ryan, I think we're ready to turn the podium back to you, and we'll be happy to entertain any questions or comments from folks in the room.
Sure, thank you all very much. Do you all mind mentioning, can you talk more about, has there been an increase that you've seen in behavioral health issues that clinicians are seeing? And if so, what are some of the stressors kind of during this COVID era?
So the one thing that we've heard people talk about is the alcohol use may have gone up and cannabinoid use may have gone up. Now, I don't know that we have any good numbers on that. One statistic that somebody threw out is that the purchase of alcohol has gone up about 300% in Oklahoma. That does not mean, now obviously most people who would be using alcohol or cannabis in a unhealthy way doesn't mean they're going to decompensate mentally and develop a substance use disorder. But we anticipate that that is one area that's going to be a problem. We had hoped that we could get SBIRT out and running to begin to help predict that, detect it, and give the advice of brief intervention for people. The second big area is, of course, generalized anxiety, and those that have had anxiety disorders in the past is somewhat more now. I don't know whether in my own social circle, we've had 2 suicides that were just really devastating. And I don't know, the clinicians haven't talked much about that, but those are things that we do talk about on our roundtable, but there's no conclusion that I can draw from it. Steve, what do you think?
I agree with you, Dan, that we haven't heard from our clinicians. We do know that, as you mentioned, the alcohol use, at least the sales of that have gone up. The sales tax on marijuana has skyrocketed according to state numbers. We've seen that, but everyone has that information. And the other is the stressors that I think families being closer together. There's unfortunately been more interfamilial violence that may have occurred too, that there's been increases in that. But I think that the stressors that our clinicians though are feeling, and I've gotten that just from being in my own setting here at the Health Sciences Center, is high, both from the clinicians that are involved to the learners, all of the staff. I think the anxiety and concern and confusion leads back to that anxiety and stress.
Thank you both very much. I just want to let people know now's the time. If you have a question for Dr. Crawford or Dr. Duffy, please type it in that chat. We do have a few minutes before they'll be wrapping up. So if you have a question, go ahead and send it in that chat and I can read it to them. But another question to sort of follow up with what you just mentioned, is it safe to assume that some of this will be sort of long-term that we'll figure out down the line? In other words, say the increase in alcohol use. Is that something that it'll take a while for you to see the adverse health effects that has, or some of these mental health issues?
Yeah, great question, Ryan. And I would agree, yes. We will probably continue to see the after effects, but it's interesting, when you talk about after effects, we may not be in the after, as it were, for quite some time. This pandemic, until we develop an effective vaccine, and I should say if we develop an effective vaccine or we get enough herd immunity, that we're going to continue, unfortunately, to have infections affect our country and our state and world. And we'll just have to, this stress will continue. And so it could be quite impacting many of our social norms and other settings. Dan?
Yeah, I agree with that. And I think that we have really no idea how long this is going to linger and what the tail of this is going to look like. I think it's going to be filled with mental illness problems. The thing that I personally am most concerned about is the loss of jobs, and the fact that we in Oklahoma as a population fall on the lower end of the income scale. There's a lot more poverty than in other parts of the country. I just don't know how fast that economic rebound is going to come and bring the jobs back. And it's particularly worrisome for the older people who have chronic conditions, who are going to be somewhat leery to return to the workplace for fear that it's a choice of income versus life. And I think that stress is going to play itself out in strange ways. I don't have any wisdom whatsoever about how to mitigate that. I do think the kindness, generosity, the ramping up of social services that we've seen in the food banks helps, but it is still a huge stress on people, particularly people who have never been in a social situation where they've needed the care and support from community services.